Okay, welcome to the deep dive. So if you've been battling through revision notes recently, maybe gearing up for those high-stakes questions where, quick recall is everything,
Hmm.
then this deep dive, well, it's pretty much made for you. We've got a stack of material that's really zeroed in on one specific condition. Think laser-focused, high-yield stuff.
Exactly right. Our source material today really distills the absolute essentials on peritonsillar abscess.
Right.
It's a condition you're almost certainly going to come across, maybe in notes, maybe in practice, often called Quinsy.
Quinsy, yeah, even the name sounds a bit uncomfortable, doesn't it? So our mission here is to take these focus notes and, well, unpack them into something clear, something memorable.
Yeah, make it sick.
We want you to finish this feeling you've got a solid grip on what Quinsy actually is, why it happens, what it looks like, what it feels like, crucially, how you spot it, and of course, how it's managed. It's about getting these facts off the page and, locked in.
Absolutely. We're aiming to build those connections, really highlight the need-to-know details, make the information, well, sticky. Think of it as us guiding you through the high-yield pathway for this condition.
Okay, let's jump right in. What exactly is a peritonsillar abscess? Let's get the definition straight from the notes.
Okay, so at its core, it's a collection of pus. Simple enough. But the key thing, the absolute key, is the location.
Right.
It's not in the tonsil itself like you might see with standard tonsillitis. It's actually in the tissues around the tonsil. The notes are specific outside the condylar capsule, but within that peritonsillar tissue.
Okay, so if I'm picturing the tonsil like a plum, it's not inside the plum.
Exactly.
It's in the soft stuff just outside the skin of the plum, like a troublesome next-door neighbor.
That's a great analogy, yeah.
Yeah.
And it doesn't just, appear from nowhere typically. The source material really emphasizes it's usually a complication, often from tonsillitis or maybe pharyngitis that wasn't treated or maybe wasn't treated effectively enough.
So the infection sort of spreads outwards.
Precisely. Think tonsillitis that's kind of gone rogue.
Okay, tonsillitis gone wrong, and the notes highlight a couple of things straight away. It's common in young adults, and it has the potential, though thankfully rare on presentation, it says, for airway obstruction. That sounds pretty serious.
It can be serious, yeah, particularly if it's left untreated. That's why spotting it early is so vital.
Yeah.
The notes also mention because the pus has bacteria in it, it can technically be contagious.
Right.
But usually the spread risk is more tied to the original infection, like the strep throat, not really the abscess itself.
Got it. So, painful pocket of pus next to the tonsil, often following on from an infection that wasn't fully dealt with. Okay, let's dig into the why. Why does this happen? What are the actual bacterial culprits? And who's more likely to end up with one?
Okay, the main cause, as the notes make really clear, is a bacterial infection. Now, while different bacteria can be involved, the key players you definitely need to remember are Group A Streptococcus, the common cause of strep throat.
Right, strep.
But also Staphylococcus aureus, and quite often anaerobic bacteria, those ones that don't need oxygen.
So not just strep, but others too, including those anaerobes.
Exactly. The notes list a few others you might see sometimes, like viridans, streptococci, Haemophilus species.
Yeah.
It's often a bit of a mixed bag, actually.
Which probably explains why they use broad-spectrum antibiotics.
Spot on. Hits more bases initially. And here's a point the notes mention that's maybe a little less expected, but good high-yield link.
Oh.
Infectious mononucleosis, glandular fever. That can sometimes be a trigger, or at least a predisposing factor. Definitely one to file away.
Mono. Okay, interesting connection. Now, what about who gets it? The risk factors. These must be important for, flagging potential cases.
Hugely important. A big one is a history of recurrent tonsillitis. So if someone's getting tonsillitis again and again.
Those frequent flyers with the sore throats?
Exactly them. They're at higher risk.
Mm.
Also, having had a peritonsillar abscess before makes you much more likely to get another one.
Makes sense.
And, like we said, inadequately treated past infections are key. The infection just wasn't fully cleared, maybe allowing it to smolder and then spread.
Yeah, if the initial problem wasn't sorted.
Right. The notes also list demographics that 15 to 30 age group is the most common window, and lifestyle factors like smoking.
Smoking too.
Okay.
Yeah.
And being immunocompromised also bumps up the risk. So you're looking for that history of throat infections, maybe a previous quinsy, age, smoking status, or a weakened immune system. Those are your red flags.
Okay, we've got the culprits and who's most vulnerable. Now, let's really get into the process, the pathophysiology. How does that initial infection actually, become this abscess next to the tonsil?
Well, the typical route, as the notes laid out, It starts with that bacterial infection in the tonsil, classic tonsillitis.
Yeah.
But instead of staying put or clearing up, the infection starts to spread outwards.
Breaks out of the tonsil itself.
Sort of, yeah.
Yeah.
Into that peritonsillar space. We talked about that tissue between the tonsil capsule and the pharyngeal muscles nearby. This spread causes a lot of inflammation. Sometimes you just get peritonsillar cellulitis first. That's the inflammation before actual pus forms. But if it keeps going, the body's immune response, fighting the bacteria in this closed-off space.
Creates pus.
Exactly. It results in pus formation, that thick fluid with dead cells, bacteria, immune cells, and this pus collects, forming the abscess. The notes say this often follows acute follicular tonsillitis, but interestingly, sometimes it seems to appear without a really clear history of preceding tonsillitis.
Oh, okay. So it doesn't always have to start with obvious tonsillitis, even if that's the usual way?
Apparently not, according to the source. And this is where the notes bring in a slightly different potential pathway, which is definitely high yield to remember. The Weber glands.
Weber glands. Never heard of them.
They're minor salivary glands. They sit just sort of above the upper part of the tonsil. And the theory here is that an infection, or maybe a blockage of these specific glands or their ducts, could lead to inflammation and then abscess formation right there in that peritonsillar space, kind of independent of a widespread tonsil infection.
Ah. So it could be the tonsil infection spreading out, or it could be a problem starting specifically in these little glands right next door.
That's the idea.
That's a really neat distinction. Gives you two ways it might kick off.
Exactly. Two potential starting points, same nasty outcome. That pus collection in the critical peritonsillar space.
Okay, right. Shifting slightly, let's talk epidemiology. Who gets this? When does it tend to show up? How common is it really?
The notes suggest it's, well, relatively common. Especially, we keep saying in young adults. That 15 to 30 age bracket really sees the highest incidence.
But older adults can get it too, just less often.
Yeah, they can, but it's notably much less common in young kids, like under 5.
And the actual numbers, did the notes give a figure?
Yeah, it mentions around 30 cases per 100,000 people,
Yeah.
specifically in the 5 to 59 age range, often cited in, like, UK data. So, it's not super rare. You will encounter it.
Definitely not a zebra then.
No. And interestingly, there seems to be a seasonal pattern. The notes mention peaks often in the cooler months, say November, December, and then again in spring, maybe April, May.
Does that link up with anything?
It mirrors pretty well the typical seasons for group A strep infections, like strep throat.
Ah, okay. So, quick memory link. Think Quinsy season, strep throat season. Nice.
Good way to remember it.
All right, so that's the background. But for actually spotting Quinsy, the clinical presentation is everything, right? What does it feel like? What does it look like? What are the absolute must-know signs and symptoms from these notes?
This is absolutely crucial, yeah. The number one symptom, severe sore throat. And the key thing here, it's often unilateral. Much, much worse on one side.
Unilateral severe sore throat. Okay, strike one.
Then painful swallowing, adenorophagia. It hurts, like a lot to swallow anything.
Right, painful swallowing, strike two.
Then you get some really distinctive signs, things that often get asked about in exams or are key clinical clues. Difficulty speaking, specifically sounding like you're trying to talk with, well, something hot in your mouth. The notes call it the hot potato voice.
Ah, the classic hot potato voice. I've heard that term. It's almost a mnemonic in itself. What's actually causing that sound?
It's basically the massive swelling and pain back there in the throat. It physically restricts how things move, changes the resonance, makes speech sound muffled, maybe a bit rushed, like you're trying to get the words out quick.
If the imaginary potato burns you.
Got it. Perfect. What else is distinctive?
Trismus. That's difficulty opening the mouth wide. The muscles around the jaw can go into spasm because of all the inflammation and pain nearby.
Okay.
This can make just looking inside the mouth really difficult.
Wow. So if someone presents with a terrible one-sided sore throat, that muffled hot potato voice, and they can barely open their mouth, Quinsy should be right at the top of your list. Absolutely. Bingo. Then you'll likely have the general infection symptoms too. Fever, feeling generally unwell, malaise, rundown.
Standard stuff.
Yeah. Earache is common too, often on the same side as the bad throat pain. That's usually referred pain.
Yeah.
And you'll probably find tender, swollen lymph nodes in the neck again, often worse on the affected side.
So it's not just the throat, it's affecting nearby things too. What about what you actually see when you examine them? Assuming you can get them to open up a bit despite the trismus.
Right. If you can get a look, you might notice fetid breath. That's a bad smell.
Yeah.
Often points towards those anaerobic bacteria we mentioned.
Okay.
Drooling can happen simply because swallowing is too painful, so saliva pools. elevated temperature, obviously. But the absolute key things to look for are that unilateral swelling and bulging of the tonsil area on the bad side. It looks pushed inwards, maybe forwards.
A swollen tonsil pushed over to one side.
Yes. And probably the most classic visual sign is displacement of the uvula.
Yeah.
The dangly bit at the back.
Yeah.
It gets pushed away from the swollen, affected side. The abscess is swelling up on one side and literally shoving everything else over.
Uvula pushed away. Got it. That's a really strong visual clue from the note.
It's critical. You might also hear the term medial tonsil shift. Difficulty swallowing, dysphagia will be obvious. The notes might mention things like furred buccal mucosa. You need to assess for that peritonsillar cellulitis. We talked about the inflammation around the tonsil. And really importantly, always check for dehydration.
Right, because they just can't drink easily. Big practical point.
Exactly. And while the notes do say airway compromise is rare when they first present, you're obviously keeping a very close eye on the airway because of where all this swelling is happening.
Makes sense. Constant vigilance.
And the notes really hammer this home. If you suspect a peritonsillar abscess, it warrants a same-day referral to an ENT specialist. No waiting around.
Okay, recognize the signs, refer urgently. Got it. So once you suspect it based on that clinical picture, how do you actually confirm the diagnosis?
Well, primarily, the diagnosis is clinical. Those signs and symptoms we just ran through, the sore throat, the voice, the trismus, what you see, combined with the examination findings, that's often enough for someone experienced to make the call.
So the story and the look are often enough?
Often, yes. But you might do some investigations to back it up or get more detail.
Like what?
Standard things like blood tests. You'd look for signs of infection, a raised white blood cell count, maybe high inflammatory markers like CRP. A throat swab can be useful too, try and culture the bacteria involved. That can help guide antibiotic choices later on.
Okay, basic infection workup. What about imaging? Do you always need a scan?
The notes say imaging, like a neck x-ray or maybe a CT scan might be considered, but usually that's for cases that are a bit atypical or the diagnosis isn't totally clear, or perhaps if there's a concern the infection has spread deeper into the neck.
So not routine for a classic case?
Generally not. If the clinical picture is classic hot potato voice,
Yeah.
deviated uvula, all that, you might well proceed without imaging initially. However, the notes do highlight ultrasound as being particularly helpful.
Ultrasound, how so?
Well, it can be used at the bedside, and it's good for helping differentiate between just cellulitis, that inflammation, without a distinct pus pocket, and a true abscess, which does have pus. And importantly, it can help pinpoint the best, safest place to stick a needle in for drainage.
Ah, okay. So ultrasound helps clarify if it is an abscess and helps guide the treatment. That's a really useful dual role to remember.
Exactly. And just quickly on that mononucleosis link, the notes mention that screening for mono can be considered, especially in younger adults, say under 30, but it's not usually essential for diagnosing the abscess itself.
Right, more of an associated factor. Okay, so we spotted it, we've confirmed it. How do we actually get rid of this thing? What's the management plan, according to the notes?
Management really has two main parts: medical support and actually dealing with the pus. Medically, supportive care is vital. Because swallowing hurts so much, dehydration is a real risk, so IV fluids are often needed.
Hydration first. Makes sense.
And pain relief. Good, strong analgesia is absolutely crucial for comfort.
Okay, fluids and pain meds. Then antibiotics.
Definitely. Antibiotics are critical to tackle the underlying bacterial infection. The notes specify using broad-spectrum intravenous IV antibiotics initially. That's to cover that range of likely bacteria we talked about earlier.
Gotcha. Any specific ones mentioned?
Examples given in the source are things like clindamycin or maybe ampicillin sulbactam, given IV to get high levels quickly.
IV antibiotics hit it hard. Anything else on the medical side?
Yeah, the notes suggest considering a single dose of intravenous steroids.
Steroids, why?
They can help damp down the inflammation and swelling quite quickly. This might speed up symptom relief and recovery when given alongside the antibiotics.
Okay, so IV fluids, pain relief, IV antibiotics, maybe a shot of steroids. But the nights seem to really stress the surgical side getting the pus out. Why is drainage so key?
Well, the source material suggests drainage is often preferred, partly because of concerns about changing bacterial types and maybe antibiotic resistance. Antibiotics alone might just struggle to penetrate and clear out that established pocket of pus effectively.
Right.
You really need to physically remove the pus to get rapid relief and properly resolve the infection in that specific space.
You got to drain the swamp, basically. What are the ways to do that?
The notes list the standard options. First is needle aspiration, just using a needle and syringe to suck the pus out.
Okay.
Second is incision and drainage, or IND. That's making a small cut with a scalpel over the abscess to let the pus drain out freely.
Aspiration or a small cut. Got it. What else?
And the third option mentioned is Quinsy tonsillectomy. This means actually removing the tonsil at the same time as dealing with the abscess.
Taking the tonsil out right then and there, that sounds like a bigger deal.
It is, and the notes suggest needle aspiration or IND are probably the more common first-line approaches. The Quinsy tonsillectomy might be considered in certain situations, but it's not always the go-to.
Okay. What if the first attempt at aspiration doesn't work, or it's hard to find the right spot?
That's where ultrasound comes in again. The notes mention using ultrasound guidance during the aspiration procedure if needed. Helps you aim the needle accurately.
Ah, ultrasound guiding treatment again. Very useful.
Very. The notes also talk about interval tonsillectomy. This isn't done immediately. It's removing the tonsils later, maybe weeks or months after the abscess is completely resolved.
Why do that later?
It's typically for patients who have a history of chronic or recurrent tonsillitis, or maybe they've had multiple peritonsillar abscesses. It's basically to prevent it from happening again.
Ah, okay. A preventative measure for repeat offenders. What about that immediate Quinsy tonsillectomy? Is it common?
The notes state that doing it immediately is actually quite debated. Some evidence, especially from pediatric studies mentioned in the source, hasn't shown a clear significant advantage over just draining the abscess first and then maybe doing an interval tonsillectomy later if needed because of recurrence history.
So the jury's still out a bit on taking the tonsil out straight away.
Seems that way. The decision really depends on the specific patient, the severity, the surgeon's assessment, hospital protocols, lots of factors.
Right. So drainage is the immediate priority aspiration or incision usually, plus antibiotics and support. Tonsillectomy is sometimes immediate, but maybe more often considered later for recurrence. What are the absolute, non-negotiable principles of managing this?
The notes are crystal clear on this. Number one priority is ensuring a patent airway. Assess and manage any obstruction immediately. That trumps everything.
Airway first.
Always, always. And then reiterate that surgical drainage is the primary definitive treatment for the abscess itself to get that immediate relief. Tonsillectomy, whether immediate or interval, comes into play in specific situations like failed drainage, maybe significant airway risk, or that history of recurrence.
Okay. Airway, drainage, antibiotic support, got the core picture. So once it's treated properly, what's the usual outcome, the prognosis?
Generally, it's very good. The notes say with prompt diagnosis, proper drainage, and the right antibiotics, most people recover fully without any long-term problems.
Okay, that's good news.
However, the flip side, which the notes strongly emphasize, is that untreated Quinsy, or significantly delayed treatment, massively increases the risk of complications.
Right, which brings us to prevention. Can you actually stop Quinsy from happening in the first place?
Well, prevention really boils down to treating the potential underlying cause, those bacterial throat infections. The notes state that treating sore throats, like strep throat, with antibiotics does offer a moderate benefit in preventing peritonsillar abscess formation.
Moderate benefit. So it helps, but it's not foolproof.
Exactly. Not a guarantee. And this links back to that really interesting observation from the notes we touched on earlier.
The one about antibiotic prescriptions.
Yeah. The fact that apparently a documented fall in antibiotic prescribing for sore throats in children hasn't actually led to a corresponding increase in hospital admissions for Quinsy in that group.
That still feels a bit backwards. You'd think fewer antibiotics for sore throats would mean more complications like Quinsy, right? What could that imply?
It does make you think, doesn't it? It raises questions about what the primary drivers really are. Is it simply having the bacteria present? Or are other things more critical in deciding if a simple tonsillitis escalates into an abscess? Maybe it's host factors, maybe the specific virulence of that particular bacterial strain, or maybe the conditions within that peritonsillar space that allow spread. Perhaps those are more decisive than just whether early antibiotics were given for any sore throat.
So the path from sore throat to abscess isn't just a straight line.
It seems more complex than just A leads to B if you don't give drug C. It's definitely something worth pondering. The pathway might be more nuanced.
That's a great point for deeper thinking. Now, you mentioned complications if treatment is delayed. Let's talk about those dangers. What can actually go wrong here?
Yeah, understanding the risks really underscores why quick management is so important. Firstly, recurrence. The abscess can just come back later. The infection can spread nearby, causing more widespread cellulitis. Or worse, it can track down into the deep neck spaces. These are really serious because they contain vital structures, blood vessels, nerves, the airway.
Deep neck space infection sounds bad.
It is bad,
Yeah.
very serious, and really severe, thankfully rare cases, this spread could even lead to necrotizing fasciitis. That's when tissue starts dying off rapidly. Nasty stuff.
Definitely nasty. What else?
Airway compromise. We said it's rare on presentation, but it's a critical potential complication if the swelling gets out of hand. Also, aspiration pneumonia if pus or infected stuff gets inhaled down into the lungs.
Right.
The infection can also become systemic, spreading through the bloodstream, leading to sepsis. That's a life-threatening, body-wide inflammatory response.
Sepsis is obviously a major concern. Did the notes mention any specific rare syndromes?
Yes, Lemire syndrome was mentioned. It's rare, but incredibly serious. It's where the infection spreads to the internal jugular vein in the neck.
The big vein.
Yeah, it causes a blood clot there, which can then break off and send infected emboli, little pieces, to the lungs or other parts of the body. It's severe high mortality if not caught and treated fast.
Wow. That really highlights the potential for systemic spread.
Absolutely.
Yeah.
There are also potential complications just from the treatment itself, mainly hemorrhage, bleeding, especially after a tonsillectomy done when everything's inflamed.
Leading risk from the surgery?
Yeah. And then the most severe, potentially fatal complications mentioned are things like the abscess eroding into one of the major blood vessels in the neck, leading to massive bleeding, or the infection extending downwards into the mediastinum.
The mediastinum. Where's that?
That's the central part of your chest, between the lungs. Contains the heart, the major blood vessels coming off the heart, the trachea, esophagus. Infection spreading there is catastrophic.
Tracking down into the chest near the heart. Okay, that paints a very clear picture of just how serious this can get if things go wrong.
It really does. It underlines why, as the notes stress, prompt diagnosis, effective treatment especially, that drainage and careful follow-up are absolutely crucial. These severe complications aren't common, thankfully, but they are real possibilities if Quinsy is missed or treatment fails.
Okay, so let's try and wrap up this deep dive on peritonsillar abscess, or Quinsy. Key takeaways. Remember, it's that pus collection outside the tonsil, usually stemming from a bacterial infection, often tonsillitis, that's spread. The really high-yield clinical clues are that severe, often one-sided sore throat, the painful swallowing, adenophagia, difficulty opening the mouth, G-trismus, and that classic hot potato voice. Plus, look for the uvula being pushed away from the bad side.
Spot on. Diagnosis relies heavily on seeing those signs, that clinical picture, though ultrasound can be a really useful tool both for confirming there's pus and for guiding the drainage.
Right. And management is all about supporting the patient IV fluids, pain relief, hitting the bacteria hard with IV antibiotics, and most importantly, getting that pus out, usually with needle aspiration or incision and drain.
Yep, drainage is key.
While the outcome is generally good if you catch it and treat it quickly, letting it linger dramatically ups the risk of some really serious, even life-threatening complications, deep neck infections, sepsis, even spread to blood vessels or the chest.
Nailing down these core points from your revision notes gives you a really solid base for recognizing this condition and understanding why timely action is so important.
Absolutely. And maybe keep mulling over that interesting point about prevention. The fact that antibiotics for all sore throats only have a moderate effect on stopping Quinsy, and fewer prescriptions haven't seemingly led to more cases in kids. What does that really tell us about the deeper factors driving Quinsy development? It's a good reminder that sometimes the pathway to complication is more complex than just the initial bug. Something to think about as you review.